Guru. Same with me. It was a pleasure to watch him at St. Louis. I just wrote an email that whether he could join or not. In the morning, he told me that he was very busy with a meeting which has come up just now. So I don't think he can join. But if he joins in the next few minutes, Guru, please inform me so that at the end of the interview, which is pre-recorded, you can have a couple of minutes with him.
Okay.
So the presentation can run. Deepak, you can start the presentation. Good evening. It's a real pleasure to go through this interview process of none other than Dr. Larry Lenke. Before going into the interview process, I would like to thank Dr. Lenke for accepting this interview at a very, very short notice. As you all agree with me that he's one of the busiest person in the spine deformity world. And for him to accept this invitation at such a short notice, I'm really grateful to you, Dr. Larry Lenke. Can you just make some first comments before I start the slideshow? And there we go.
Well, first of all, thank you, Dr. Basu, for even giving me the honor of looking and reflecting upon my career a bit, hopefully for the benefit of the younger surgeons that have aspirations to do complex spine deformity work. As I told you in through email chain, I'm not one to really want to reflect much on my successors or awards or trophies and things, because that doesn't mean as much to me. What means so much to me is helping patients, helping surgeons do better to help their patients. And that's why I'm honored to do this type of interview with you. So thanks again for the opportunity.
Okay, we'll go on with the slideshow. Okay, so it is a real pleasure to interview the living legend, Dr. Larry Lenke. The first slide shows that what happens if you type Lawrence Lenke. About 170,000 searches in 0.59 seconds. And that's what is the ripple effect of Dr. Larry Lenke. When I asked for his interview, he sent me a CV and said, Basu, this might help. And believe me, I couldn't get the guts to go through this CV because it is 290 pages. More than 500 published abstracts, more than 1,000 presentations. He has kept a meticulous record of all his fellows, which is more than 500 possibly, all his guest lectures, all his videos, all his patents. Before going further, Larry, how did you make this tumultuous effort of building up this CV?
Oh, I have a lot of help. Obviously, one of my keys, and I'll say this at the very end, is surrounding yourself with good people. Obviously, you have to put yourself in a good position, and you have to work hard. And it's easy to work hard if you enjoy what you're doing. So I've been very fortunate I've loved what I've done in my career, and also have surrounded myself with very good, hardworking people as well, which makes this type of productivity much easier to accomplish.
On a lighter note, Larry, if you type Lawrence Lenke on the Google, do you know what questions people ask? The first and foremost is, what's his salary? And the next one is, what's his age? And if you go down a little bit more, what is Larry Lenke worth? What net worth? I didn't know that these were the important questions which people asked.
Yeah, I asked my wife that, Basu. I don't know. Yeah, I don't even know that. My wife has all those as all knowledge.
Right. I'll just begin with my interactions with you. I do not remember whether I do not know whether you remember or not. I first interacted with you when I won a GOP fellowship in 2004 Buenos Aires SRS annual meeting. By that time, you had already become famous because your publication of the Lenke curves in EIS had come out in 2000. And it was a very oogling moment for me to stand beside you to take a photograph. And then only I decided that I must join you at some point in time. And the moment came in 2010 when I was a visiting fellow in St. Louis. And I cherished some excellent moments. This is one of the most difficult cases, and this is the only one spinal deformity I've seen in my life, in which the whole lumbar spine was translated anteriorly and the sacrum of the pelvis was behind, which was a 35-year-old lady with an in situ fusion. She had at 5-6 years of age, and these were the clinical photographs. And there, we did not have 3D printing at that time in my country, so this is the first time I saw a 3D model. And I don't know whether you remember this case. Does this ring a bell, Larry?
I do remember this. This actually is a publication. I did 3 of these, Basu, in the course of around 5 or 6 years. Posterior vertebrectomies for severe fused spinal apoptosis, and it's published in Spine Deformity. She's one of the 3 cases.
So it's one of 3 out of 5,000 spine deformities. I was the lucky guy.
Very unusual.
And the same day, believe me, it was your 50th birthday, and no holidays, no cutting down on OR schedules. You had a very long day, and then you were accosted with a cake, and the OR staff asked you to cut the cake. And before leaving to the clinic, you said in the corridor, "Basu, I know I'm sniffing something wrong." And the clinic was cancelled, and there it was in the clinic with all the celebrations of your 50th birthday. Do you remember that?
I do remember the surprise. Yeah, I didn't expect at all, including my lovely wife and children were there. So that was quite a pleasant surprise. The best
Yes, and in the lower picture, you can see that you're grinning and sheepishly moving out, embarrassed to the hilt, because you didn't know that your family was invited at all.
Exactly.
And then you were very gracious enough to accept my invitation, and within 2 years, you came down to a very small hospital where I worked, and we had the first of its kind park clinic update on spinal deformities. And this is a picture taken in my room, and I still remain grateful to you for that. And then the big event came in 2014. You remember you came down for the SRS worldwide course, and it was fantastic that we had 10 SRS faculty. You can see Harry Schaffelberger, you can see Munish Gupta, Hilali Nurdin, Mark Wadenbaum, Steve Glassman, Marinus D. Cliver, and that was a fantastic show. And again, your lectures, your recorded versions in that course still comes up, and people praise the lectures which you've given us for that in 2014. And I'm proud to have you as the first co-author in this publication of an AO Spine research grant. Thank you again for guiding me to that. And I'm grateful to your contribution to Indian Spine Journal, the current concepts in level selection for fusion and AIS. So you get so many of these, requests across the world regarding contributing to various journals. And I've seen you hardly refuse your near and dear ones. And I'm again grateful to you for this.
Okay.
Tell us about your childhood, Larry.
So I was born in the south side of Chicago. The south side is kind of the rough side. The north side is the more affluent side. My parents were basically high school educated. I was the first in the family to attend college. My dad basically went directly from high school to working as an apprentice in a printing factory. So he was responsible for printing of things like Time magazine and Newsweek. Those are popular American magazines. My mom actually was a secretary for an orthopedic surgeon in suburban Chicago. And after school, I used to go to his office because my mom didn't want me at home. So I basically grew up playing around in his plaster clinic. And I used to work with putting plaster on my arm as a young child. So maybe probably my interest in orthopedic surgery began with that. I really enjoyed playing a lot of sports. I wasn't very good at it, but I enjoyed the competitive nature of sports and the teamwork of sports. And I also played a lot of chess, which I didn't realize probably was helpful in my future career as a spinal deformity surgeon, because as you know, a complex spinal deformity operation has thousands of chess moves that you have to plan real time and also sometimes change on the fly, right? So I think playing a lot of chess in my youth and my teenage years definitely helped me to develop the kind of mental fortitude and planning ability, I think, of doing spinal deformity surgery. The other thing I want to mention, this is kind of crazy, but there was a girl in my grade school that I went to grade school with for like 12 years straight. Her name was Susie, and I don't remember her last name. I don't remember much about her, but I do remember that she basically had a kind of ear on shoulder deformity. I'm getting old, I can't even put my ear on her shoulder, but she had probably a congenital, maybe clipophile, congenital type of cervical thoracic deformity where her ear was stuck on her shoulder. And she had very bright red hair, so couldn't be missing. She used her hair to kind of cover her deformity because she was so offset. But all the kids made fun of her, and I really kind of felt sorry for her because she, it wasn't her fault that her neck was so deformed. But that was my first introduction to spine deformity. I had no idea what that was a spine deformity, but I remember that I really felt sorry for her. I also remember all the ridicule that she got from all the other students weren't very nice to her. So, maybe that in some way also made me somewhat receptive to the difficulties of patients with deformity. But I just mentioned that because I do always think of that now later in my life.
So do you still play chess in your leisure time?
I don't. I'm just too tired. I don't have enough mental energy. I did teach my children to play chess when they were growing up, but I honestly don't play much now. I think I have my chess during the day doing surgery all day long, right?
So you went to University of Notre Dame and then to the Northwestern University Medical School, and then your training as well as you became an attending in St. Louis. Huge,
Yeah.
long years. I think 18, 20 years you spent there.
Basically training nearly 30 years in St. Louis for 6 years of training and almost 23 years of being an attending. So obviously, I mentioned this, all these universities, these are obviously very, very well regarded universities. And I was very fortunate, to get into Notre Dame, Northwestern, and WashU for my training, and then out of Columbia now, obviously. And again, just putting yourself in a good position, right? I mean, just very, very fortunate from the beginning to have my training and my work at such prestigious institutions, but not only for myself, but all the people around me that are so talented, right?
And for the 18 years that you were an attending as a spine deformity surgery, I mean, this was a crazy schedule, shall we say? 5 days in the OR and 3 days in the clinic, working 16 hours, 18 hours a day.
Yeah, it was true. The only thing that saved me, Basu, was that I traveled a lot. So I would work for a week or two, and I'd go to a meeting for a couple of days, because otherwise I don't think I could keep the schedule up. But the bottom line is that it did allow me to get a lot of experience, as doing a deformity. Experience means so much, and repetition is so vital, right?
One interesting thought came into my mind. When I was at the airport receiving you for a small spine conference at Kolkata, and when I was there in the airport and I asked you, how much do you sleep? And you said that it is 5 on an average, more towards 4.5 than 5. Do you still sleep that much, or
Yeah,
you increased your sleeping?
Yeah, I sleep a little more now. Getting not enough sleep is not good for your health, and I learned that the hard way. So I definitely suggest getting more sleep. We all know that, right? I mean, there's good medical evidence, right? But honestly, for probably 25 years, I didn't get more than 4 or 5 hours of sleep most nights. On the weekends, I would get a little more. But the bottom line is you have to take care of yourself, and sleep is important.
So to quote unquote, you have done the most number of spine deformities, and possibly you're still doing the number of spine deformities, which is unparalleled in the United States. And I think I cannot be more grateful to you when I hear that you're the most prolific spine deformity surgeon in the entire US. Tell us about your cherished moments at St. Louis and which mentor left the most indelible mark on you.
Well, obviously, I really gained my strife, my roots in St. Louis, both during my training and my fellowship with Keith Bridwell. Obviously, I definitely need to put him first as my greatest mentor. After Ron DeWald, after I met Ron DeWald as a medical student, and I trained with him as a medical student. He was at Rush University in Chicago, but I did a rotation with him for a month. And he introduced me to Keith Bridwell in WashU, because as you know, Bridwell was trained by Ron DeWald. So that's the DeWald to Bridwell, now hopefully Lenke lineage that I'm proud to carry. Just tremendous memories in St. Louis, getting my initial foray into deformity through Bridwell, getting my own practice set up at the Shriners Hospital, at the Children's Hospital, at the Adult Hospital, having this tremendous opportunity at WashU and tremendous people, being from the Midwest of the United States. St. Louis and Chicago are very close to each other, so a very comfortable beginning. Great people. Washington University is a premier medical center. As you know, you visited me there. So nothing but great things to say about both St. Louis and Washington University, and obviously my greatest mentor, Keith Bridwell.
How long did you work with Keith Bridwell as a fellow or a resident?
Well, 5 years as a resident and 1 year as a fellow, so 6 years of training, and then I was with him for 23 years as an attending, so nearly 30 years, Basu.
So I was really proud to be in the department, because in that single department, you had so many SRS active members. I can see Dan Ryu, I can see Jacob Bukowski by your side, and of course, the great Creed Bridwell.
Right.
So this is a slide which you've provided me. And as you've correctly said, the deformity surgery can not only save lives in the pediatric kids, but also for the adults, it can optimize the quality of life. But in this scenario, and I know that you are a very, very, very stringent believer of the fact that everything can be done posteriorly. In fact, when I first met you in Washington, you said that I have not done an anterior surgery for the last more than 10 years, Basu, and I still believe that posterior is the way out. So at this point in time, do you really feel that there is still a scope of anterior surgery in some specific instances?
Oh, absolutely. And, one of the issues with anterior surgery during the 1990s, and I performed a lot of it, was just the morbidity of the formal anterior open thoracotomy or thoracoabdominal approaches. Remember, these are big, open, invasive surgeries, right? And so, honestly, I love doing the surgery. The surgery technically was phenomenal. I did my own anterior approaches. If I happened to tear the vena cava, I sewed it up myself. So I was a real surgeon. The problem was that following that big anterior surgery, we still needed to do a big open posterior surgery. So the morbidity for the patient was too much. But now, obviously, many surgeons are getting very facile at minimally invasive anterior surgery. So that definitely has now sparked an increased role for anterior surgery in deformity. And obviously, I think that's great. My challenge then is to see, well, how can I replicate what people are doing from the front as well as from the back, minimally invasively, and do it from the back from a more open approach, but decrease the morbidity to make it more equal, right? And that's my challenge. And also, I must suggest that in severe deformity, especially when we're doing things like vertebral column resection, we are doing anterior surgery. I work in the anterior spine a lot. I just do it from a posterior reach around approach, right? So it's not like I don't do anterior surgery. I just don't come in from the side or from the front. I just come in from the back.
So you've dedicated your career to severe deformities. There are a few examples. I've seen a lot more in your slides, which I've been hearing intently for the last 10, 15 years. Tell us about your worst case. What went wrong and how did you cope up with?
Obviously I've had several, paraplegics, early post-op, most of them actually from either vascular phenomenon or like spinal cord strokes. I had one just 2 months ago, 8 hours after surgery with normal data, normal wake up in the ICU. The mean pressure just dropped a little bit and became acutely paraplegic. So, those are crushing problems, right? Especially when, there's no consistent mechanical reason for that. But probably my worst case overall was a case probably 15 years ago in St. Louis. It was the mother of one of our infectious disease doctors who had a long-standing adult kyphoscoliosis, very severe, very rigid, but she's a functional lady. And I decided to do her in 2 stages just because she needed a very aggressive PSO, but also a T2 to sacrum procedure. She needed decompressions of stenosis, so she needed a lot of work. And she was a bit on the frail side. I think she's 60 years old, so I decided to do it on 2 days. But my mistake was that I did her 3 days apart. And so I did a Monday, Thursday combination. Monday surgery went fine. And Thursday morning, I saw her on rounds. And what I didn't know is that right after I saw her and before she got to the OR, she dropped her O2 saturations a bit. So she needed to be put on oxygen. And I didn't know that. So when we started the surgery, i.e. the problem was her lungs were already a little bit filled with some fluid and material. So we started the surgery and immediately her oxygen saturation started dropping about an hour into the second stage surgery. And pretty soon, basically she completely decompensated. Her saturations went down to the 50s. She coded. We performed a CPR. We cracked her chest. I got the cardiothoracic surgeons in. We did open cardiac massage on her for an hour or two in the OR, in my OR, and she expired during the surgery. And just a crushing blow. And I had to tell her son, who was an infectious disease specialist, that their mother had passed away during surgery, and just a horrible situation. But again, learning point is that now I never stage surgeons. If I do stage surgery, I don't do it that often, but if I do stage a very complex deformity, I have at least 1 or 2 weeks in between the surgeries. Their lungs have to be clean. Their myocoagulopathy has to be sorted out. So you want them, fresher for the second stage surgery. And so I learned a very valuable lesson from that, unfortunately. and the patient had to pay the ultimate sacrifice, right, by her demise. But the bottom line is this is a tough business. If you aren't willing to kind of put up with these kind of complications, it's hard to be a complex deformity surgeon. But at the end of the day, we always need to use these type of horrible tragedies and any complications to make surgery better, right? We need to make ourselves better and do better for our patients. So that's why I've put a lot of emphasis. If you look at my CV, a lot of my papers are on avoiding complications, assessing complications, making surgery safer, because at the end of the day, we owe that to our patients, and I owe that to my colleagues to use my experience, to help others make surgery safer.
Absolutely. So let's come down to the earth-shattering classification system, which is undoubtedly the most widely cited spine deformity publication that has come out possibly in this century. So regarding this, I have two questions. What led you to think about the necessity of a new classification? And what is the future from a 2D to a 3D?
So basically, the impetus for this classification was that I was using the King system, obviously in my early career, and as we know, it's not thorough. There's some curves that aren't classified. Major thoracic lumbar curves aren't part of it. Triple major curves, and number two is that we were trying to figure out, what's better for a thoracic curve, an anterior approach that Jürgen Harms was promoting, or a posterior approach that people like David Schuffelbarger was promoting, and we couldn't classify them reliably. I was in the Harms study group, and no one could agree on the classification. So I was thinking there as a young surgeon saying, how are we ever going to figure out what the best way to treat something is? We can't agree on the classification. So that was the impetus to come up with a new system that was more reliable and more complete, obviously, for having all curves being classified. Obviously, we are moving towards 3D classification. The reason it's been slower, though, is that it does require a 3D assessment, which it needs to be done either with CT scans, which is too much radiation, and now is still in the supine position, or with total body images through like the EOS system, but not everyone has that system. So there's a lack of input to allow for 3D classification. But as soon as that becomes commonplace, obviously 3D classification will become very common and used as it should be, because obviously AIS is a 3D deformity.
So do you think that the 3D classification is the way ahead, but there are challenges regarding the infrastructure required to develop such a scheme?
Exactly. So as soon as infrastructure challenges are completed, then we'll have 3D classification.
Tell us something about the SRS. It's been a very, very long association which you had with the SRS heading committees, and I think you're the most frequently. You've been the nomination committee chairman, picking up the mentors and picking up the persons who would run the SRS, the leadership qualities you're identifying, and what makes SRS different from other societies. And if you could tell us a few words about the future of SRS.
So what makes SRS different, number one, are the people involved, and they're committed to spine deformity surgery. Spine deformity surgeons are a different breed, I think. It's tough surgery, right? I mean, it's the highest of highs and the lowest of lows at times, and it requires an extreme amount of clinical competence, an extreme amount of work ethic, time in the OR. You have to get things right. You can't skip steps in spine deformity surgery. Ultimately, your patient pays a price. So I think the spinal deformity surgeons are wired a bit differently, and we think differently. And to be surrounded with those type of people in the SRS is, to me, very stimulating. And that's why I think it's different in other societies. The future of that society, obviously, and it's headed that way. I tried to start it during my presidency, has become more global. I think you would agree, Basu, that many surgeons from India are benefiting from that. That SRS course in 2014 was one of the best courses I was ever at. Phenomenal attendance, phenomenal question and answer discussion periods, phenomenal interest, and I think dedication from the surgeons present at the meeting. So I think there's many other countries and surgeons around the world that will benefit from SRS engagement. That's slowly happening, and will continue to excel forward in the future.
And I have no hesitation in telling you that globalization of SRS was your brainchild, and as the years pass by, SRS is really, really becoming global. Now let's come down to the big move, the big move, the leap of a giant. The entire team moves out from St. Louis to New York. So what made you move, and why did you leave St. Louis, and how is New York different?
Well, I think it was a bit of a risk for me to leave St. Louis. As you know, I had a great practice there, right? Everything I needed. But why I left basically was for the profession of spine surgery. You know, spine surgery, especially complex spine deformity surgery, is a specialized area of medicine and surgery that really requires expertise and resource allocation from the universities and the hospital systems. And basically, Columbia University and the New York-Presbyterian hospital system were willing to commit resources to create a specialized spine hospital with all the resources and personnel needed for that, where St. Louis wasn't. And that's why I went. I didn't go for personal gain, because if anything, it was a risk that I wouldn't have the same practice. I left because to elevate the nature of spine surgery into those specialized areas of surgery like cardiac surgery, transplant surgery, that have always been received as needing a very large resource allocation, right, and specialized personnel. Well, guess what? Spine surgery does too, and we're proving it by our move to St. Louis, and move to New York, and it's worked out great. I'm very, very pleased. It's been a great career move. Certainly, I miss my people in St. Louis. Obviously that goes without mentioning. It was a very hard move, and it will always be a difficult move. But again, at the end of the day, if the profession of spine surgery, not only in the U.S. but in the world, benefits from it, then I'm grateful I made the move.
And I'm sure you now have a 10-surgeon consortium of spine deformity surgeons. And for the first 5 years, I think it was a challenge. Now that the COVID is really gone, I'm sure you'd be all the more blessed with the next few years of developing a fantastic spine hospital. I still remember your daily morning rounds. You start at 6:30 to 7. And I still remember your 27 years of weekly pre and post conference. And do you think in this context, when you're going through all these conferences and when you're going through all these rounds, do you really think that MIS is the future of adult deformity surgery?
Oh, it's going to play.
What is your take at this point in time about the mini-open anterior approaches or the minimally invasive lateral fusions?
Yeah, so I'll tackle the second question first. Yeah, obviously, as I mentioned, doing less invasive anterior surgery is certainly beneficial. Again, I don't do it, but my partners do. They do a very nice job. In their hands, it works. So that definitely is a huge step forward the last 5 to 10 years development of things like L-lip and O-lip. MIS is going to play a role, for obviously more straightforward deformities, more primary deformities. I think I'm not sure anytime in the near future that complex resection type of surgeries are going to be best done through MIS approaches. I mean, and the reason I say that also is, you have patients. I have patients that have just unbelievably extensive, all day spinal reconstructions, and within a few weeks, they're really doing pretty well. As long as they have a good attitude, the surgery is done well, their wound heals well. They really recover quite nicely. So although obviously it's always better if we can do things a little less invasively, I would say that a good open surgery in a very motivated patient can still have an outstanding outcome. And so that's why we shouldn't completely get away from open surgery, but we still should slowly improve on our MIS approaches over time. And I think there's going to be a melding of that over the next 10 to 20 years, Basu.
So your weekly schedule has come down from 5 ORs a week to 3 ORs and 1 day full admits and 1 day full clinic. So in a typical clinic on Wednesday, how many patients would you see, and how many of them are follow-up, and how many of them would be new patients?
Yeah, well, pre-COVID, I basically had 2 clinics a month, seeing around 30 patients in each clinic, 5 to 8 new patients, and the rest follow-ups. I'm very fortunate. I only see new patients, follow-ups, and pre-ops basically. All my patients are screened, as you know, even in St. Louis, I think when you were with me, you saw that. So I've got a very boutique kind of practice, and still have. So it's I can focus only on spinal deformity. That's very fortunate to have that kind of practice.
And what about Ron Lehman telling you that navigation and robotics is the future? Do you differ with him? Do you have a fight?
Oh, not at all. I mean, again, as soon as robotics are better and faster than me putting in screws, I'm using it. But right now, at least to the fellows, the fellows work with Lehman, the fellows work with me. They said it's going to slow me down still and not make me as accurate. But, again, there's no reason why next 5 years we don't have a robotic arm that puts in 10 or 12 pedicle screws simultaneously, right? And then it's going to be faster and better. So that's certainly going to happen. I'm just kind of waiting for that day, and I'll let people like Layman kind of sort out all the details until that happens. Okay.
So next is, I know you love teaching, and within 2015 to 17, you have more than 100 visitors and fellows, and you meticulously have the 50 fellows pictures pasted there. Who was your most outstanding fellow and visitor? I know that you've more than 500 of them.
Yeah, well, the visitor one is easy. It's a guy named Dr. Basu from Calcutta, India. Amazing guy. He was my most important and famous visitor. I've trained over 100 fellows. It's hard to pick out the favorites. Obviously, people like Ron Lehman come to mind. I've stuck with me. Hanjo Kim at HSS is a phenomenal surgeon fellow. Mike Kelly, who's back in St. Louis, is a phenomenal surgeon and academician. So a host of will come to mind. Steve Lewis, chief of deformity surgery in Toronto, Canada. The list goes on and on. But I'm very fortunate. I call it my extended family. Obviously, I have a wife and 3 children as my immediate family, and over 100 fellows that are my extended family.
So when you see your children growing up, by the way, tell us about your children. You have 3, I believe. What are they doing now, and how are they posted in life?
So I'll start with my son, who's a middle child. Actually, Brad is in finance in New York City, who's going to start Columbia Business School next fall, one of the top business schools in the world. So he's very excited about that. My youngest, second from the left in the far right picture, is Erin. She actually works for a company called Executive Search here in New York City as well. And her job the last year and a half has been to recruit nurses and therapists to work in hospitals. And guess what? With the pandemic, she's been incredibly busy working 7 days a week, 20 hours a day, because it's such a need. So she's keeping very busy right now, but doing a very good service to align nurses and therapists in the hospital positions. And then my oldest daughter, Lauren, is based out in Los Angeles, but she's been actually with Beth and I living with us since she got married in October. So she's recently married to a New York gentleman. And Lauren is a social worker. And interestingly, she is a graduate of Columbia Master's Program in Social Work. And my wife, Beth, is a current student in that same program, getting her master's in social work right now. So my wife, when I'm recording this live, is actually back at home on virtual school and classes for getting her master's degree from Columbia University in social work. So I admire both of them very much.
Absolutely. So would you ever want to see your son or your daughter becoming a doctor?
I'd love to do that. Unfortunately, I think they saw or they didn't see their dad home enough because of the hours I put in when they were younger. So none of them elected to go into medicine. I would have loved to seen that, but bottom line is I want them to do what they're happy with in life, and all 3 of them are very satisfied with their roles in life, and I'm very proud of all 3 of them.
So your extended family include the colleagues and staff at WashU, spinal surgeons around the world, more than 100 fellows trained, and more than 5,000 patients treated. This is your real-time hero, and I really wonder the excellent support she's given you over the decades that you've been with her. And as they say, that every success story has a woman behind. And I'm sure Beth is an extraordinary person, extraordinarily supporting you throughout these years to make you a living legend, Lawrence Lenke.
And that's the most understatement thing you can say, Basu, because what you just said is so much an understatement. Beth is an amazing lady, amazing lady.
I'm sure she's amazing, Larry. And we'll just talk a minute about the Lenke Family Foundation, giving back to the society, before you tell us your last words, your confessions, and your message to the young surgeons.
All of us in this profession are very fortunate, right? And I think it's important to give back in one way or another. So you can do it in many ways. You can do it financially, as Beth and I have done with our foundation. And you can also do it with service. I've done the outreach surgery in various locations around the world. And you just do it basically by volunteering in local environment. Right now, especially around the world with pandemic, there's so many needs, right? Whether it's donating time to give vaccines or to give out food to those in need. I mean, we are all very fortunate. So in one way or another, please give back. And I guarantee you, it is true that giving back means so much more than receiving. You'll be the beneficiary of that.
I wanted to read the young surgeon's message yourself, right?
So my advice is to work hard, but make sure you enjoy what you work at, because it'll make that much easier to do. You need to surround yourself with the best and honest people and lead by example. You need to basically go about your profession with patients and your colleagues with confidence, by not being cocky or arrogant. That's not going to help you at all. And my other quote is, no one is perfect, but our patients deserve us to strive for perfection during our deformity surgery.
Thanks, Larry. And we end with your confessions.
As you can see, I tried to express that I am the luckiest person in the world. But interestingly, the harder I work and the better I treat people, the luckier I get. My other quote is, it's certainly better to be lucky than good, but it's best to be lucky and good. So you need to get the training you need to do a good job with surgery, and your patients will benefit from that.
I would say, Dr. Lenke, that not only you're lucky and good, but you're good and lucky.
There you go.
And with these last statements, I think you've sent a very strong message to the young surgeons of India, and the confessions of legend are awesome. I take this opportunity to once again thank you, Dr. Lenke, for joining us, and it has been a fantastic experience talking to you, cherishing my moments with you for the last 30 minutes. Thank you.
That's
Have a very nice day.
Thanks, Basu. Thank you. Good luck to the rest of your meeting. Appreciate it.
Thank you.
I think that was a lovely Basu.